Hello everyone, we're assigned to discuss the different kinds of gastrointestinal disorders. In this video, we will identify the pathophysiology of various GIT disorders such as GERD, ulcer, and motility disorders. Then, we will discuss their treatments. Our first topic is the gastroesophageal reflux disease. So what is GERD? Gastro refers to the stomach. Esophageal stands to esophagus. Reflux means to flow back. So therefore, gastroesophageal reflux disease is when stomach acids flows back to the esophagus. Pathophysiology combines from the words patho or pathology, which is the study of the causes and effects of disease. Physiology is the study of how systems of the body function. In other words, we will talk how GERD affect the systems of the body, causing functional changes that can lead to health risks. As we can see here in the left picture, the esophagus is a part of the gastrointestinal tract which is responsible of moving the food from the mouth to the stomach. As our food reaches the stomach, it becomes acidic. It is because in our gastric glands, we have our parietal cells that releases specifically hydrochloric acid, a potent chemical produced by the cell lining of the stomach which makes our stomach acidic. The esophagus has anti-reflux barrier which prevents acidic content of our stomach return back to our esophagus. The anti-reflux barrier consists of the lower esophageal sphincter or known as LES and the related part of the diaphragm. The lower esophageal sphincter has a smooth muscle and therefore are not under voluntary control. When the lower esophageal sphincter is working properly, as we can see in the left picture, it relaxes and opens when you swallow and then it tightens and closes again afterwards. In the right picture, in this case, we have a relaxed lower esophageal sphincter and an inflamed esophagus which allows our acidic stomach juices or food and fluids back up from the stomach into the esophagus. These are the common signs and symptoms of GERD. First, we have chest pain, which is a burning sensation in your chest, usually after eating, which might be worse at night. We have unwanted bitter taste in the mouth, regurgitation of food or sour liquid, coughing, nausea, dysphagia, are also known as difficulty in swallowing.
What is ulcer? Ulcers are sores that are slow to heal or keep returning. They can take many forms and can appear both on the inside and outside of your body. Injuries, diseases, and infections can cause them. What they look like depends on where you have them and how you got them. While some go away on their own, others cause serious problems if you don't treat them. Esophageal ulcer. An esophageal ulcer is a distinct break in the margin of the esophageal mucosa. This mucosal damage to the esophagus is often caused by gastroesophageal reflux disease or from severe sustained esophagitis from other causes. Gastric ulcer or stomach ulcers are open sores that develop with the lining of the stomach has become damaged. Duodenal ulcer. A duodenal ulcer is a peptic ulcer that develops in the first part of the small intestine. An esophageal ulcer occurs in the lower part of your esophagus. Peptic ulcers are open sores that develop on the inside lining of your stomach and the upper portion of your small intestine. Pathophysiology of esophageal ulcers. It is caused by gastroesophageal reflux disease or GERD, occurs when excessive reflux of acid and pepsin results in necrosis of the surface layers of esophageal mucosa, causing erosions and ulcers. The prolonged period of gastric acid exposure and bile salts often determines the extent of an esophageal mucosal injury. Other contributing factors to ulcer formation include decreased contraction of LES, causing reduced gastric acid clearance from the esophagus. Furthermore, persistent chronic GERD with a decreased resting tone of the upper esophageal sphincter can precipitate laryngopharyngeal symptoms such as throat clearing, chronic cough, and sore throat. Ingestion of alkalis, such as ammonia or sodium hydroxide, acutely results in a penetrating injury causing liquefactive necrosis. The acid-induced injury typically produces a superficial coagulation necrosis that thromboses the underlying mucosal blood vessels and consolidates the connective tissue, causing a protective scar. Peel-induced esophageal ulceration occurs from local burns exerted by the peels on the esophageal mucosa. This occurs more with peels that have low pH, causing a destruction of the cryoprotective barrier of the mucosa and forming an ulcer. Most often, an esophageal ulcer is caused by a bacterium known as Helicobacter pylori, or H. pylori for short. The bacteria damage the mucosal lining of the esophagus. This makes the esophagus more susceptible to damage by stomach acid. The signs and symptoms of esophageal ulcer are pain when you swallow or trouble swallowing, pain behind your breastbone or heartburn, feeling of food sticking in your throat or not going down right, upset stomach, vomiting blood, and chest pain. The pathophysiology of gastric ulcer. We all know that H. pylori bacteria weakens the protective mucus coating of the stomach and duodenum, thus allowing acid to get through to the sensitive lining beneath. Both the acid and the bacteria irritate the lining and cause a sore or ulcer. NSAID medications are the other most common etiology causing gastric ulcers. Patients who use these medications have a relative risk of 4 for developing gastric ulcers when compared to people who don't. There are multiple mechanisms by which NSAID medications lead to ulceration. The drugs themselves are weak acid when they become exposed to gastric acid. They remain in the epithelial cells and lead to increased cellular permeability, which leads to physical cellular injury. The primary mechanism of NSAID-induced ulceration is the decrease in prostaglandin synthesis. NSAIDs inhibit the cyclooxygenase 1 enzyme, which usually increases prostaglandin synthesis, which in turn leads to gastric bicarbonate secretion, mucus barrier formation, increased mucosal blood flow, and accelerated epithelial cell restitution and repair after injury or cell death. NSAID medications allow the gastric mucosa to become more vulnerable to gastric acid and pepsin damage. Overall, the most harmful physiological damage results from the decrease in gastric blood flow and the mild ischemia it causes in the gastric mucosa. Gastric ulcers occur when a thick layer of mucus that protects your stomach from digestive juices is reduced. This allows the digestive acids to eat away at the tissues that line the stomach, causing an ulcer. So, what causes stomach ulcers? Stomach ulcers are almost always caused by one of the following: an infection with the bacterium Helicobacter pylori, or long-term use of non-steroidal anti-inflammatory drugs or NSAIDs such as aspirin, ibuprofen, or naproxen. What are the signs and symptoms? The most common symptom is a burning sensation or pain in the middle of your abdomen between your chest and belly button. Typically, the pain will be more intense when your stomach is empty, and it can last for a few minutes to several hours. Other common signs and symptoms of ulcer include dull pain in the stomach, weight loss, not wanting to eat because of pain, nausea or vomiting, bloating, feeling easily full, burping or acid reflux, heartburn, which is a burning sensation in the chest, pain that may improve when you eat, drink, or take an antacids. Anemia. Those symptoms can include tiredness, shortness of breath, or paler skin, dark tarry stools, vomit that's bloody or looks like coffee grounds. H. pylori and NSAID use are the two main underlying etiologies to consider and discussed here. The mechanism by which H. pylori predisposes individuals is unclear. However, the thinking is that H. pylori colonization and persistent inflammation leads to weakening of the mucosal surface layer, causing it to be vulnerable to exposure to gastric acid. A secondary running theory considers the possibility that H. pylori can increase acid production via inflammatory mechanisms, further exacerbating the initial injury caused by the infection and initial acid-driven injury. Prostaglandins play a crucial role in the development of the protective mucosa in the gastrointestinal tract, including both gastric and small intestine mucosa. Their biosynthesis is catalyzed by the enzyme cyclooxygenase, which exists in two isoforms, COX-1 and COX-2. NSAIDs inhibit their therapeutic effect by inhibiting the COX-1 and COX-2 pathway. Recurrent use of NSAIDs cause a significant and persistent decrease in prostaglandins, leading to susceptibility to mucosal injury. It is thought to be one of the primary predisposing pathophysiologic factors for the development of duodenal ulcers. Other secondary causes for duodenal ulcers may work through different underlying mechanisms. However, the ultimate result is generally recurrent mucosal injury that predisposes the tissue to ulceration, or an elevation in the amount of acid the mucosa is exposed to, which in turn causes tissue damage. The signs and symptoms of duodenal ulcer. Having pain in the stomach or abdomen. Having indigestion, feels very full and bloated after eating, feels like you might vomit, and loses weight.
Gastrointestinal motility disorder. When we talk about GI motility disorder, it is a digestive problems that result when the nerves or muscles of the gut do not work in a coordinated way. There are many types of digestive motility disorders. Some of these are diarrhea, constipation, and irritable bowel syndrome. Some only affect one portion of the digestive tract. Others involve or progress to multiple areas within the digestive tract. First is diarrhea. It is defined as passage of abnormally liquid or unformed stools at an increased frequency, usually a symptom of an infection in the intestinal tract, which can be caused by a variety of bacterial, viral, and parasitic organisms. People of all ages can get diarrhea, but it is more common in children below 5 years of age. There are common sources of diarrhea that we've known. First is poor personal hygiene, improper sanitation, contaminated water and food poisoning. But also, there is a cause of diarrhea. It can be infection by bacteria, infections by other organisms and preformed toxins. Could also be an allergies and intolerances to certain foods. It can be the cause of the medications that we intake. And lastly, a poor absorption of food or malabsorption of food. Types of diarrhea. First is the acute diarrhea, which is the most common. It is a loose watery diarrhea that lasts on 1 to 2 days, and this type doesn't need treatment and it usually goes away after a few days. Next is persistent diarrhea. This type of diarrhea generally persists for several weeks, like 2 to 4 weeks. Chronic diarrhea. It is a diarrhea that lasts for more than 4 weeks or comes and goes regularly over a long period of time. Signs and symptoms. For mild diarrhea, you could feel bloating or cramps in the abdomen, a strong and urgent need to have a bowel movement, and upset stomach. For severe, you could feel fever, you lose weight, dehydration, severe pain, and vomiting. Next is constipation. Constipation occurs when bowel movements become less frequent and stools become difficult to pass. It happens most often due to changes in diet or routine or due to inadequate intake of fiber. Constipation, this include especially for older people. They tend to be less active and have a slower metabolism, less muscle contraction strength along their digestive tract than when they were younger. And for women, especially when pregnant or after childbirth, there is a changes in women's hormones make them more prone to constipation. The baby inside the womb squishes the intestine, slowing down the passage of stool. And the common is not eating enough high fiber foods. And it can also be the cause of taking certain medication. Complications. First is hemorrhoids. It is swollen, inflamed veins in your rectum. Diverticulitis, an infection in pouches that sometimes form off the colon wall from stool that has become trapped and infected. Fecal impaction. It is a pile up too much stool in the rectum and anus. Anal fissures. It is tears in the lining of your anus from hardened stool trying to pass through. Its causes. First and foremost, the common cause of constipation is eating foods low in fiber, not drinking enough water, not getting enough exercises, changes in your regular routine such as traveling or eating or going to bed at different times, eating large amounts of milk or cheese, stress, or resisting the urge to have a bowel movement. Signs and symptoms. You have fewer than 3 bowel movements a week. Your stools are dry, hard, and or lumpy. Your stools are difficult or painful to pass. You have a stomach ache or cramps. You feel bloated and nauseous. You feel that you haven't completely emptied your bowels after a movement. And lastly, irritable bowel syndrome. It is not a disease, it's a functional disorder, which means that the bowel simply does not work as it should. It is a long-term gastrointestinal disorder that can cause persistent discomfort. It is a common disorder that affects the large intestine. Its signs and symptoms could be cramping, abdominal pain, bloating and gas, constipation, and diarrhea. Its causes is the abnormal GI tract movements, the sensory and motor disorder of the colon, a neurotransmitter imbalance, which is a decreased serotonin levels, and stress. Its pathophysiology. First is the alteration in GI motility. It is an alteration in frequency and irregularity of luminal contractions. Second is the visceral hypersensitivity. It is an increased sensation in response to stimuli. Third is the brain-gut axis, an alteration in communications between enteric nervous system and the CNS. And lastly, the post-infectious. It is about 10% of the IBS cases triggered by an acute gastroenteritis infection.
So let's talk about the treatment of gastrointestinal tract disorder, which is we have to be specific. Let's talk about the treatment of ulcers. So what are those? We have five. Then the histamine, which is the H2 receptor antagonist blockers. We have antacids, proton pump inhibitor, which is the PPI. We have antibiotic and the combination therapy. So what are those histamine receptor blockers? This drug blocks the release of hydrochloric acid. As we all know, our stomach is acidic in response to gastrin, and also preventing histamine from binding to its receptor in peripheral cells. So what are those antacids? This drug interact with the gastric acids in the chemical level to neutralize them. Also the PPI, this drug suppress the secretion of hydrochloric acid into lumen of the stomach. Also stimulation of protein kinases that phosphorylate the hydrogen and the potassium ATPase. Also, what are those antibiotic? If Helicobacter pylori is found in your digestive tract, your doctor may recommend the combination of antibiotic to kill bacterium. And the combination of drug therapy regimens commonly used to treat an Helicobacter pylori infection. So let's talk about that later. Let's move on to the H2 blockers, which is the tidines. We have the cimetidine, ranitidine, famotidine, nizatidine. And what are the pharmacodynamics of these drugs? We have antagonists at the receptors in the peripheral cells of the stomach, and also blockage result in inhibition of the hormone gastrin. And there will be decreased production of gastric acid from the peripheral cells, and also the cell shifts will secrete less pepsinogen. So the therapeutic use of H2 blockers, we have short-term treatment in active duodenal ulcer or benign gastric ulcer. We have treatment for hypersecretory condition like the Zollinger-Ellison syndrome, and prevention on stress-induced ulcer and acute gastric intestinal bleeding, and treatment of erosive GERD, which is the reflux disease, and the relief of symptoms of heartburn and acid indigestion. So the precaution and contraindication of the H2 blockers, we have any known allergy is clear contraindication to the use of the agents. We have conditions such as pregnancy, lactation, renal dysfunction, and hepatic dysfunction should warrant cause cautious use. And nizatidine can be used in hepatic dysfunction. For the side effects and adverse effects of the H2 blockers, we have the gastrointestinal tract, the diarrhea or constipation. In the central nervous system, we have dizziness, headache, drowsiness, confusion, and hallucinations. In the cardio part, we have arrhythmias, hypotension related to H2 receptor blockage in the heart, and in the cimetidine, the gynecomastia and impotence in male. For the drug-drug interaction, the cimetidine, famotidine, or ranitidine are metabolized in the liver. They can cause slowing of excretion of other drugs, leading to increased concentration. These drugs can be anticoagulants, phenytoin, alcohol, and antidepressants. Antacid, these are drugs or inorganic chemicals that have been used for years to neutralize acid in the stomach. As we go back earlier, it neutralized in the stomach, and the following are the common antacids that can be bought OTC, over the counter. We have the aluminum salts, which is the hydroxide, calcium salts, the carbonate. We have magnesium salts, the milk of magnesia, sodium bicarbonate, and the magaldrate, which is the combination of aluminum and magnesium. So for the two types of antacids, we have systemic and non-systemic. For the systemic, we have the sodium bicarbonate for alkalosis. For the non-systemic, we have the aluminum hydroxide. It absorbs trypsin and removes it from solution at pH and lesser than 3, and relaxes stomachs and delays get. It stimulates secretion of the mucus enhancing mucosa barrier to acid. We have also for diarrhea, we have the magnesium hydroxide, and for the rebound acidosis, we have the calcium carbonate. And the antacid pharmacodynamics, the drug action, we have these agents act to neutralize acid pH in the stomach, and they do not affect the rate of gastric acid secretion. The administration of antacid may cause an acid rebound, and neutralizing the stomach content to an alkaline level stimulates gastrin production to cause an increase in acid production and return the stomach and its normal acidic state. So the antacid's therapeutic indication is we have symptomatic relief of upset stomach associated with hyperacidity, and the hyperacidic condition like peptic ulcer, gastritis, and esophagitis, and the hiatal hernia. So the antacid's precautions: known allergy is clear contraindication. Caution should be instituted if electrolyte imbalances, the gastrointestinal obstruction, and the renal dysfunction. So also we have the antacid pharmacokinetic. These agents are taken orally and act locally in the stomach. So the antacids pharmacodynamics, these are the effects of drugs in the gastrointestinal tract. The rebound acidity, alkalosis may occur. For the calcium salts may lead to hypercalcemia and milk alkali syndrome. Also, the magnesium salt can cause diarrhea. The aluminum salts may cause constipation and hypophosphatemia by binding with hyphosphates in the GIT. Number 2, we have the fluid retention due to the high sodium content of antacids. Proton pump inhibitors, these are the newer agents for the ulcer treatment. We have the prazoles. The prototype is omeprazole, and we have lansoprazole, esomeprazole, and pantoprazole. For the proton pump inhibitor pharmacodynamics, which is the drug action, that they act as specific secretory surface receptor to prevent the final step of acidic production and thus decrease the level of acid in the stomach. So the pump in the parietal cells is the hydrogen and potassium ATPase enzyme system on the secretory surface of the gastric parietal cell. Or we have the 3 therapy, which is the omeprazole plus clarithromycin plus amoxicillin or the metronidazole. For the PPI clinical use, we have the short-term treatment of active duodenal ulcer. the GERD, which is the gastrointestinal reflux disorder. We have the erosive esophagitis and benign gastric ulcer. So for the long term, the maintenance therapy for healing of erosive disorders, precaution with the use of the PPIs or the proton pump inhibitors. Known allergy is clear contraindication. Caution if the patient is pregnant. So what are the PPIs? Pharmacodynamics or the adverse effects. In the central nervous system, we have dizziness, headache, asthenia or the loss of strength. We have vertigo, insomnia, and apathy. In the gastrointestinal tract, we have diarrhea, abdominal pain, nausea, vomiting, dry mouth, and tongue atrophy. For the respiratory, we have cough, stuffy nose, hoarseness, and epistaxis. The Clostridium difficile colitis, if the patient must be counseled to discontinue the proton pump inhibitor therapy if they have diarrhea for the several days and to contact their physician. For the possible increased risk of fractures of the hip, wrist, and spine, the greatest risk is associated with the patient taking the PPIs for 1 year or greater. Move on to antibiotic. If the Helicobacter pylori is found in your digestive tract, your doctor may recommend a combination of antibiotics to kill the bacterium. This may include the amoxicillin, the erythromycin, which is the Biaxine, metronidazole or Flagyl, tinidazole or Tendamax, tetracycline, and levofloxacin. For the optimal therapy of the patient with a peptic ulcer disease infected with Helicobacter pylori requires the antimicrobial treatment. So, the endoscopic biopsy of the gastric mucosa or the various non-invasive methods are used, including serologic test and urea breath test to document infection with Helicobacter pylori. So, eradication of Helicobacter pylori results in rapid healing of active peptic ulcer and low recurrence rates. We have the example of one example drug of antibiotic. We have the cimetidine. So, in the specific, the dosage of all the drugs must be decreased in patients with hepatic or renal failure. Cimetidine inhibits CYP450, leading to many interactions. So, the adverse effect, we have headache, dizziness, diarrhea, muscular pain. Cimetidine can also have endocrine effects because it acts non-steroidal anti-androgen. So, these effects include gynecostomia and galactorrhea. Drugs such as ketoconazole, which depend on the acidic medium for gastric absorption, may not efficiently absorb when taken with H2 blockers. The combination of drug therapy regimen, the common use of treatment in the Helicobacter pylori infection include the following options. We have two. We have a proton pump inhibitor, the PPI plus clarithromycin plus amoxicillin or metronidazole. On the other hand, we have a proton pump inhibitor plus bismuth compounds plus metronidazole plus tetracycline. So here, from the A, we have only three, the PPI, the clarithromycin, amoxicillin, or the metronidazole. But in the B, we have four, a PPI, a bismuth compound, metronidazole plus tetracycline. So, the prepackaged drug combination, some of the recommended drug combination are packaged together for convenience. We have the bismuth, subcitrate, potassium, and metronidazole, and tetracycline, the Pylera. The bismuth, subcitrate, and metronidazole, tetracycline, like the same. We have Helidac, and the lansoprazole, PPI, and amoxicillin, and clarithromycin, we have Prevpac. And also we have the PPI and amoxicillin and clarithromycin also, which is the omeprazole, while here is the lansoprazole. So how does the combination of drug works? The right antibiotic combination usually kill Helicobacter pylori bacteria that are cause many peptic ulcers. At least 2 antibiotics are used because combination treatment works better is likely to fail because of resistance to antibiotics. So why it is used? Combination drug therapy that includes at least 2 antibiotic and acid reducer, and sometimes a bismuth compound is recommended for people who have peptic ulcer disease and known to be infected in Helicobacter pylori. So how will it work? Helicobacter pylori infections are cured 70 to 85% of the time when the right combination drug treatment is used. And for the common side effects of the medicine, the combination of the medicine, we have headache, dark colored tongue, and dark colored stools caused by the bismuth. And we have the mild diarrhea, mouth sores, and vaginal itching or discharge.
Drugs for motility disorder. So the first classification of drugs for treatment of motility disorders are the prokinetic agents. So these stimulate gut motor functions. They increase lower esophageal sphincter pressure, which may be useful for the treatment of GERD. They also stimulate the small intestine, which may be beneficial for the post-operative ileus or the chronic intestinal pseudo-obstruction, and enhance colonic transit, which may be useful in the treatment of constipation. These prokinetic agents are the metoclopramide and domperidone. So metoclopramide and domperidone are dopamine D2 receptor antagonists. They block dopamine D2 receptors in the chemoreceptor trigger zone of the medulla or the area postrema, resulting in potent anti-nausea and anti-emetic action. Within the gastrointestinal tract, activation of dopamine receptors inhibits cholinergic smooth muscle stimulation. So they increase esophageal peristaltic amplitude. This refers to peristalsis, which is the progressive wave of contraction and relaxation of a tubular muscle system, or in this case, the esophagus. Increase lower esophageal sphincter pressure and enhance gastric emptying, but have no effect on small intestine or the colonic motility. So prokinetic agents are used in the treatment of GERD or the gastroesophageal reflux disease. So prokinetic agents are used mainly in combination with anti-secretory agents in patients with regurgitation or refractory heartburn. So for the treatment of impaired gastric emptying, metoclopramide is sometimes administered in hospitalized patients to promote advancement of nasoenteric feeding tubes from the stomach to the duodenum. For non-ulcer dyspepsia, which lead to symptomatic improvement in a small number of patients with chronic dyspepsia. And for the prevention of vomiting, so metoclopramide and domperidone are used for the prevention and the treatment of emesis because of its potent anti-emetic action, and for postpartum lactation stimulation, in which domperidone is sometimes recommended to promote postpartum lactation. The most common adverse effects of metoclopramide involves restlessness, drowsiness, insomnia, anxiety, agitation, extrapyramidal effects like dystonias, akathisia, and Parkinsonian features, tardive dyskinesia, which is sometimes irreversible, and elevated prolactin levels, which can cause galactorrhea, gynecomastia, impotence, and menstrual disorder. By the way, this is caused by both metoclopramide and domperidone. While domperidone is extremely well tolerated because it does not cause the blood-brain barrier, and neuropsychiatric and extrapyramidal effects are rare. So for side effects, patients taking metoclopramide may experience involuntary muscle movements, facial grimacing, dystonic reactions resembling tetanus. While for domperidone, patients will experience headache, dizziness, dry mouth, nervousness, flushing, irritability, having trouble with sleeping, stomach cramps, hot flashes, and leg cramps. So other prokinetic agents also include neostigmine and the macrolide erythromycin. Anti-emetic agents. So there are different classes of drugs that have antiemetic properties, such as the corticosteroids dexamethasone and methylprednisolone, which enhance the efficacy of 5-HT3 receptor antagonists for acute and delayed nausea and vomiting. Antipsychotic agents such as olanzapine, which attribute to the inhibition of dopamine and serotonin receptors, and antihistamines and anticholinergic drugs. These classes of drugs all have antiemetic properties, but I will talk about serotonin 5-HT3 receptor antagonists, which have the most potent antiemetic properties. So, antiemetic agents treat nausea and vomiting that could be side effects of other drugs, and treat motion sickness, stomach flu, chemotherapy, post-operative nausea and vomiting, and morning sickness. An antiemetic agent that can be used is the serotonin 5-HT3 receptor antagonist. It has potent antiemetic properties that are mediated in part through central 5-HT3 receptor blockade in the vomiting center and chemoreceptor trigger zone. The antiemetic action is restricted to emesis, attributable to vagal stimulation and chemotherapy. It does not inhibit dopamine or muscarinic receptors, and it does not have effects on esophageal or gastric motility. It is used for treatment of chemotherapy-induced nausea and vomiting, in which the drug is most effective when given as a single dose by intravenous injection 30 minutes prior to administration of chemotherapy, and post-operative and post-radiation nausea and vomiting, in which the drugs are used to prevent or treat post-operative nausea and vomiting. And so, the commonly reported adverse effects of antiemetics are headache, dizziness, and constipation, then prolongation of the QT interval and serotonin syndrome, which has been reported in patients taking 5-HT3 receptor antagonists in combination with serotonergic drugs such as the SSRIs or selective serotonin reuptake inhibitors and SNRIs or the serotonin norepinephrine reuptake inhibitors. And so, patients taking antiemetics for a longer duration may experience severe hypotension as side effects. Antispasmodics. These agents promote relief of abdominal pain or discomfort and aids in the treatment of irritable bowel syndrome. Commonly used medications are dicyclomine and hyoscyamine. Dicyclomine inhibits muscarinic cholinergic receptors in the enteric plexus and on smooth muscle, and it works primarily through anticholinergic activities. Hyoscyamine is a tertiary amine antimuscarinic. It blocks the action of acetylcholine at parasympathetic sites in the smooth muscle, secretory glands, and the central nervous system. And it increases cardiac output, dries secretions, and antagonizes histamine and serotonin. Adverse effects with taking dicyclomine includes dry mouth, constipation, stomach pain, gassing or bloating, and loss of appetite. While with hyoscyamine, there will be palpitations, ataxia, urticaria, lactation suppression, impotence, urinary hesitancy, weakness, mydriasis, and decreased sweating. Patients taking dicyclomine might experience dizziness, blurred vision, nausea, lightheadedness, especially with the injectable form, drowsiness, and nervousness, and with hyoscyamine comes insomnia, heartburn, changes in taste, impotence, problems with urination, nervousness, and nausea and vomiting. Laxatives. So fun fact, we don't actually need laxatives. It's just that there are some part of the population that does or has to. So constipation can actually be prevented with high fiber diet, adequate fluid intake, and frequent exercise. But laxatives are mainly used for the treatment of constipation. There are different types of laxatives. First are the bulk-forming laxatives, which are indigestible, hydrophilic colloids that absorb water, forming a bulky emollient gel that distends the colon, and it promotes peristalsis. The common preparations include psyllium and methylcellulose, which are natural plant products, and polycarbophil, which are synthetic fibers. And then the stool surfactant agents or the stool softeners. So they soften stool material, allowing water and lipids to penetrate. They may be administered orally or rectally. Common stool softeners include docusate, which can be given orally or through enema, glycerin suppository, and mineral oil, which lubricates the fecal material, retarding water absorption from the stool. And then osmotic laxatives has two types. First are the non-absorbable sugars or salts, which are used for the treatment of acute constipation or the prevention of chronic constipation. Agents like magnesium hydroxide or milk of magnesia is a commonly used osmotic laxative, and then sorbitol and lactulose, which can be used to prevent or treat chronic constipation. And then some are used for the treatment of acute constipation or to cleanse the bowel prior to medical procedures, for example colonoscopy, like magnesium citrate and sulfate solution. And sodium phosphate, which is infrequently used due to the high risk of hyperphosphatemia, hypocalcemia, hypernatremia, and hypokalemia. And then the balanced polyethylene glycol, which is used for complete colonic cleansing before gastrointestinal endoscopic procedures. So this is designed so that no significant intravascular fluid or electrolyte shifts occur. But compared to sorbitol or lactulose, polyethylene glycol does not produce cramps or flatus. And then the last type of laxative are the stimulant laxatives or cathartics, which directly stimulates the enteric nervous system and colonic electrolyte and fluid secretion. And lastly, diphenylmethane derivatives such as bisacodyl, which is for the treatment of acute and chronic constipation. However, this is safe for acute and long-term use. So adverse effects of taking laxatives include rectal bleeding, bloody stools, severe cramps or pain, unusual tiredness, and skin rash or itching. And we already know the effects of prolonged use of laxatives, but its side effects include electrolyte disturbances or imbalances, dehydration and mineral deficiencies, permanent damage to the digestive system, chronic constipation, and damage to the nerves and muscles of the colon. And the last group of drugs for treatment of motility disorders are the antidiarrheal agents. So antidiarrheal agents are used for the treatment of mild to moderate acute diarrhea, and it should not be used with bloody diarrhea, high fever, or systemic toxicity. And the different classes for antidiarrheal includes opioid agonists, which have significant constipating effects. Opioid agonists increase colonic phasic segmenting activity and decrease mass colonic movements and the gastrocolic reflex. Common drugs are loperamide, which is a non-prescription opioid agonist which does not cross the blood-brain barrier and has no analgesic properties. Then prescription drug diphenoxylate, which if prolonged use can lead to opioid dependence. And another prescription opioid agonist, eloxadoline. Then bile salt binding resins, cholestyramine, cholestipol, or cholesevelam, which may decrease diarrhea caused by excess fecal bile acids. And octreotide somatostatin, which is a 14 amino acid peptide. So clinical uses for antidiarrheal agents are for the inhibition of endocrine tumor effects, in which octreotide decreases secretory diarrhea and systemic symptoms through inhibition of hormonal secretion and may slow tumor progression, and of course diarrhea. Adverse effects include steatorrhea, which can lead to fat-soluble vitamin deficiency, alterations in gastrointestinal motility, which is the cause of nausea, abdominal pain, flatulence, and diarrhea, inhibition of gallbladder contractility, and development of acute cholecystitis, which is the inflammation of gallbladder. And the side effects include abdominal pain, constipation, some dizziness, and nausea and or vomiting.